This presentation is going to examine the effect of clinical experience and judgment in the prevention of fatal pulmonary emboli. We know that there's a disparity between academic guidelines and clinical practice because often the patients that you see in clinical practice aren't the kind of patients that were tested in the guidelines. So you have to have more than just those guidelines. So let's take a look at a situation here in a 37-year-old imaginary female who had morbid obesity with a BMI of 48 and 4 children. She fell at work and fractured her kneecap and was placed in a leg brace in full extension. Her aunt had a history of a blood clot at age 45 without known cause. It just occurred out of the blue. And that made her a second-degree relative to the patient. The surgeon knew about this, but did not think that this was important for the clinical situation the patient was in at the current time. 9 days after she was put in the brace, she was scheduled for an operative repair of the fracture, which is normally a simple outpatient procedure. Shortly following the application of the tourniquet after anesthesia was started, she suffered a cardiac arrest, and despite the fact that she was under ideal conditions with the anesthesiologist and the surgeon, they couldn't resuscitate her. And this happened shortly after they exsanguinated her leg with an S-mark bandage, which they do prior to putting the tourniquet on. The clinical team was shocked and astonished. What went wrong? Well, extensive clots in the legs and lungs were found at autopsy. This DVT is not surprising given this whole clinical scenario compounded by the family history of thrombosis. This family history is the single most overlooked yet very important factor in calculating a person's risk. Immobility, obesity, leg swelling, increased pain preoperatively, and fracture were added risk factors increasing her risk, in addition to the fact that she was going to have a tourniquet placed. We know that full extension of the knee can close the popliteal vein, which is the major vein that drains the lower leg. And that, of course, slows blood flow out of the leg. It has to go around through the surface system, and that can be a serious risk factor for a blood clot. And if we take a look at this video, we can see this is a view of the popliteal fossa with the knee slightly bent. And when it's extended, it shuts the popliteal vein down. And as a result of that, the blood flow has to go around. The longer the leg's in this position, the greater is the risk of thrombosis. A preoperative duplex scan could have averted this disaster. So what are the lessons learned here? Guidelines do not recommend routine duplex scanning looking for DVT in asymptomatic patients, but clinical circumstances may dictate a different course of action, a scan for suspected cause. This patient experienced 8 days with the leg in full extension, marked impairment in blood flow return due to this extension, and lack of proper calf and foot muscle pumping activity resulted in a slow blood flow and made the patient a setup for developing a DVT. In addition, this patient had this family history, which greatly adds to the risk. Again, a preoperative duplex scan would have been life-saving. It's true that not all patients in a knee brace need to be scanned preoperatively, but this patient, again, to re-emphasize and go over again the risk due to the combinations of the fracture, scheduled operative repair, morbid obesity, family history of thrombosis, and anticipated application of a tourniquet. Now, the next time this surgeon sees a similar patient, do you think that he or she might choose a different course of action and maybe get that scan in order to achieve a better outcome or in order to avoid this terrible result? We must remember that preventable cause of death after surgery preoperatively is a fatal pulmonary embolism. It's number one. And I'd like to take a quote from my dear friend from Maine. Never kill a friend. Never treat a stranger. Now, what did he mean by that? Well, performing a thorough history and physical gives you knowledge about your patient as if they were a good friend. And of course, you would never ever hurt your friend, and you'd protect them to the fullest extent. So thank you for watching this video. Please see venusdisease.com, my website, for more information. And I hope you have a great day.